As a physician who's board certified in regenerative medicine and who regularly performs minimally invasive orthopedic procedures, I'm going to give you the honest answers about what works, what doesn't, and what the research actually says. Not the marketing answer. Not the dismissive, there's no evidence answer that you might get from a surgeon who has a financial interest in nothing other than doing surgery. The honest clinical answer with all its nuance and uncertainty included. I'm Dr. Trevor Turner, a precision longevity and interventional sports and spine physician at Previta Health in Atlanta. I completed training in interventional spine and sports. I perform both ultrasound and X-ray called fluoroscopy guided regenerative orthobiologic procedures, and I have no interest in overselling either one. Regenerative medicine for joints is a legitimate and clinically meaningful field. It is also a field with significant variability in quality, evidence strength, and appropriate patient selection. Today, I'm going to give you the framework to understand it clearly, but let's start by mapping the landscape. Regenerative orthobiologics exist on a spectrum from relatively simple to significantly more involved in terms of preparation complexity, biologic potency, evidence base, and appropriate indication. PRP, platelet-rich plasma, is at the entry level of the spectrum. It's prepared from your own blood, a venous draw, processed by a centrifuge to concentrate platelets above physiologic baseline, and then injected into the target tissue. Platelets are rich in growth factors, PDGF, TGF-beta, VEGF, IGF-1, that modulate tissue healing responses. It's autologous, meaning your own cells, minimally invasive, and has the broadest evidence among orthobiologics. BMAC. Bone marrow aspirate concentrate steps up significantly in biologic complexity. Bone marrow is aspirated typically from the posterior iliac crest or the back of the pelvis, concentrated and re-injected. The therapeutic component is not primarily stem cells in the science fiction sense, but it's a rich mixture of mesenchymal stem cells, hemopoietic progenitors, growth factors, and cytokines. The procedure is more involved than PRP and accordingly used for more significant pathology. MFAT. Microfragmented adipose tissue uses processed fat tissue obtained from a small liposuction procedure. The fat is mechanically processed and not enzymatically digested to yield microfragments that contain a graft rich in mesenchymal stem cells and supportive regenerative factors. This has a different biologic mechanism and cell composition compared to BMAC. Cardinova is our proprietary approach at Previta, a combination procedure that integrates the Regenilase fractional laser with regenerative medicine grafts to address chondral and osteochondral pathology. The laser component prepares the joint tissue with a precise mechanical and biological stimulus so that the biological graft can augment the regenerative response. This is reserved for specific patterns of cartilage pathology and is not a first-line intervention. Here's what most people get wrong about PRP. They treat it as a single intervention, but it isn't. PRP exists in dozens of preparation variants: leukocyte-rich versus poor, different concentrations, different activation methods, volumes, target tissues, different injection techniques. A poorly prepared, incorrectly dosed PRP delivered without image guidance to an inaccurate target is a completely different intervention from a well-characterized, appropriately dosed PRP delivered under real-time ultrasound or fluoroscope guidance to a precisely identified pathologic structure. This is why PRP literature seems like it's all over the place. It literally is heterogeneous because comparing studies requires comparing preparation protocols, and most meta-analyses struggle to do that adequately. With that caveat, what does the best evidence show? For knee osteoarthritis, intra-articular PRP has the best evidence base among orthobiologics. Multiple RCTs and systematic reviews demonstrate superior pain reduction and functional improvement compared to placebo and hyaluronic acid at 6 to 12 months. The most recent high-quality meta-analysis shows a consistent benefit, particularly for mild to moderate arthritis. It is not a cure. It does not regenerate absent cartilage in advanced disease. But for appropriate patients, it meaningfully reduces pain and improves function. For tendinopathy, like the lateral epicondyle or tennis elbow, patellar tendon or jumper's knee, gluteal tendinopathy, often called hip bursitis, the evidence is positive depending on the specific condition and the study. Chronic tennis elbow has some of the best PRP evidence in tendinopathy. Patellar and Achilles tendinopathy have reasonable supportive data, but in the rotator cuff, it's more variable. For the spine, disc, facet, and SI joint, evidence is earlier stage and more limited, although clinical outcomes in well-selected patients can be very strong. My clinical bottom line on PRP is for the right indication with the proper preparation and image guidance, I use it regularly and see consistent benefit in appropriate patients. For patients with advanced grade 3 and 4 arthritis or complete tendon tears, I'll be straight up with you. PRP alone is unlikely to be sufficient. BMAC is a step up in biological potency and a step up in invasiveness as well. So the indication needs to justify the additional burden. I use BMAC in patients who don't respond adequately to PRP or have moderate to advanced joint disease, particularly when there's significant cartilage involvement or when the structural deficit suggests a need for a more robust regenerative signal. Patients with isolated cartilage lesions and active lifestyles are often better candidates for BMAC than they are for direct surgery, where the recovery burden is high and long-term outcomes for certain cartilage repair procedures are highly variable. The evidence base for BMAC in joints is growing, but not as much as it does in PRP. Multiple case series and some comparative studies show positive outcomes for knee arthritis and for osteochondral defects. What we don't yet have is the volume of high-quality randomized control trials that would satisfy a strict evidence hierarchy. What we do have is strong mechanistic rationale, an excellent safety profile, and consistent clinical results in well-selected patients. The stem cell language around BMAC is worth addressing here because it has created both unrealistic expectations and some justified skepticism. The mesenchymal stromal cells in bone marrow concentrate do not directly regrow cartilage in any capacity that explains the clinical outcomes we observe. The mechanism is predominantly paracrine. BMAC cells secrete signaling molecules that change the biology of the local environment, reduce inflammation, and stimulate the host tissue's own healing response. That's a meaningful therapeutic mechanism. It's just not stem cells growing into new cartilage. Managing expectations around that distinction matters. A patient who expects BMAC to regenerate 5 millimeters of absent articular cartilage will be disappointed. A patient who understands it may reduce pain, slow progression, and potentially delay or avoid surgery altogether, and who has appropriate pathology for that outcome can do very well. Microfragmented adipose tissue is a relatively newer addition to the orthobiologic toolkit, and it occupies an interesting niche. The adipose-derived grafts have a high concentration of mesenchymal stem cells, higher per unit volume than bone marrow in most patients. The microfragmentation process used in systems like the Jointech Labs kit can preserve the three-dimensional microarchitecture of the tissue, which is thought to be important for cellular biological activity. This procedure requires a miniature liposuction, typically from either the abdomen or the flanks, which is processed and then re-injected under image guidance. Where I find MFAT particularly useful is for patients who may not be ideal BMAC candidates due to factors that affect bone marrow quality, either age-related bone marrow changes, prior chemotherapy, or certain metabolic diseases, but who have adequate fat tissue reserves and appropriate joint pathology. Evidence for MFAT is more early stage. Published case series and smaller controlled studies show promising outcomes in knee arthritis. The field is growing and the biological rationale is sound, but I'm transparent with patients that this is a newer intervention with a developing evidence base. Cardinova is a procedure uniquely done at Previta Health that represents our highest tier for cartilage pathology. The Regenerative fractional laser delivers precise controlled energy to cartilage tissue, creating a pattern of microstimulation that disrupts the degenerative environment and creates a pro-regenerative biologic response. This is conceptually similar to how fractional laser therapy in dermatology creates controlled microinjuries to stimulate collagen remodeling, but applied here to cartilage in knees and periarticular tissue. The laser component is then combined with regenerative biologic grafts tailored to the specific pattern of pathology, creating a combined mechanical and biological stimulus that I believe exceeds what other modalities can achieve alone. I want to be clear about where Cardinova sits in terms of evidence. This is an advanced proprietary procedure with clinical outcome data from our practice and the developing evidence base for its component technologies. It is not a replacement for PRP or BMAC in routine indications. It is indicated for specific selected patients with defined cartilage pathology who are looking to avoid or significantly delay joint replacement and who have realistic expectations about what the procedure can and cannot achieve. This is not a procedure I offer for everyone who walks in with knee pain. Appropriate patient selection is the difference between clinical success and frustration. Any regenerative orthobiologic is only effective as its delivery. Injection accuracy matters enormously. Studies comparing image guidance versus palpation consistently show significantly higher accuracy with image guidance, and clinical outcomes correlate with injection accuracy. An intra-articular injection of a knee delivered without ultrasound or fluoroscopic guidance misses the joint space in a meaningful percentage of cases. The biologic goes into periarticular fat or another off-target structure. The patient goes home thinking they received treatment, but they didn't. At Previta Health, every regenerative injection I perform is image-guided, ultrasound or fluoroscopy or both, depending on the target structure and the clinical situation. This is not optional in my practice. It is a minimum standard for delivering these procedures responsibly. If you're evaluating a regenerative medicine practice, ask them directly what percentage of your injections are performed under image guidance. If the answer is anything less than all of them, that's a red flag. Period. Then ask, what percentage of your injections are measured in terms of their cell counts? If the answer is anything less than all of them, that is a red flag. Period. Let's talk directly about skepticism in this space, because it's at least partially earned. There are bad actors in regenerative medicine. Clinics that charge $10,000 to $30,000 for procedures with no medical evaluation, no imaging of the target structure, no individualized treatment planning, and often using products of highly questionable biologic activity, or worse, products that have never been verified to contain what they claim. The FDA has taken enforcement action against clinics marketing exosome products, amniotic stem cells, and other biologics that were marketed with unsubstantial efficacy claims or that contained no viable cells. This is a real problem, and I understand why it generates blanket skepticism. Here's how I think about it. The problem is not the science of orthobiologics. The problem is the absence of physician-grade evaluation and clinical rigor and how it's practiced in some settings. A quality regenerative medicine evaluation should include a thorough history and physical of the relevant joint and region, imaging review, X-ray minimum, MRI preferred for significant pathology, clear specific diagnosis of the structure being treated, a personalized treatment recommendation with explicit rationale, honest discussion of evidence strength and alternatives, including physical therapy, surgery, and image guidance for procedure delivery. If a practice is willing to inject any joint you point to without an examination, image review, or a clear diagnosis, that is not regenerative medicine. That is a procedure mill. I can tell you what my practice looks like because I believe transparency builds appropriate trust. Every patient I evaluate for a regenerative intervention gets a diagnostic workup first. I review their imaging or conduct my own with ultrasound. I perform a physical exam. I have a conversation about what the evidence supports, what the alternatives are, and what realistic outcomes look like. Some patients I evaluate I don't treat with orthobiologics because surgery, physical therapy, or lifestyle modification is the better answer for their specific situation. That's how clinical medicine should work. Let me give you an honest framework for candidacy. Good candidates for PRP or BMAC. Mild to moderate arthritis grades 1 through 3 with preserved joint space in patients who want to avoid or delay surgery. Chronic tendinopathy that has failed appropriate conservative management, rest, eccentric loading, or physical therapy. Partial tears without complete disruption. Post-surgical adjunct use to support healing. Younger patients with isolated OCDs or osteochondral defects. And then there's patients where I have honest conversations about limitations. Grade 4 bone on bone, in quotes, osteoarthritis with complete cartilage loss. The regenerative substrate is gone and I won't promise outcomes that I can't deliver. In some of these patients, a procedure may still help pain meaningfully, but framing matters. Complete tendon or ligament tears, structural reconstruction is usually required, although biologics may be used as an adjunct to surgery. Patients with active systemic infection, inflammatory arthropathy and a flare, or platelet dysfunction disorders, patients with unrealistic expectations, will this grow all my cartilage back to normal, is a question that requires an honest no. I'd rather decline to treat somebody who isn't going to respond than take their money and disappoint them. That is not idealism, it's medicine. And frankly, it's the only way to build a legitimate practice in this space. If you have joint pain and you're trying to figure out whether any of this is right for you, the first step is an actual evaluation, not a quote for a procedure. So in the comments, tell me, what joint are you dealing with and what have you tried? I'll do my best to respond, and most common questions will become future video topics. I'm planning a dedicated deep dive on the knee specifically. If this was helpful, subscribe. I cover regenerative medicine, longevity, and precision diagnostics every week, and I don't sugarcoat it. The full blog post with the evidence citations for each modality will be linked in the description. And if you're in Atlanta or willing to travel, and you want a comprehensive evaluation of whether a regenerative approach is appropriate for your specific situation, book a consult at Provita Health. The link is in the description. I'll review your imaging, examine you, and I'll give you my honest clinical recommendation. Sometimes that recommendation is surgery, and sometimes it's physical therapy, and sometimes it's an orthobiologic procedure, but it will be the right recommendation for your situation. See you in the next one. Thank you.